Cancer presents a global public health problem. It is the second most commonly diagnosed cancer in men. As we know, there are some risk factors for developing prostate cancer. Age. This condition is rare in men under 40. So, with age, the risk increases. Ethnicity. Most common among men of African descent. Family history. Cases of those affected by this disease among relatives. Genetic mutations. Mutations in the BRCA1 and BRCA2, which also affect the development of breast and ovarian cancer, may also increase the risk of prostate cancer. Smoking and eating habits, inflammatory diseases of the prostate, sexually transmitted diseases. Some facts about prostate cancer. Most prostate tumors for a long time don't cause symptoms or cause alone minor concerns. Because of this, prostate cancer relatively often detected in the context of any examination for early detection, when the person affected does not feel discomfort yet. If the tumor is so large that it has narrowed the urethra, problems with urination may occur. For example, poor urine flow, frequent pressure to urinate, pain, or other difficulty urinating, blood in the urine. However, such concerns often arise in older men, even without the presence of cancer in prostate. In most cases, they are caused by any benign prostatic hyperplasia. Diagnosis of prostate cancers. As we know, early diagnosis is a determinant in the success of the prognosis for these patients. It is one of the most aggressive cancers when it gives metastasis, so delays in its detection can be fatal. If caught early, the cure rate is almost 99%. Early detection and treatment are crucial in saving lives. Nowadays, prevention is the best way to ensure complete health in the population, and for this, in the case of many diseases, screening tests are performed to result in health protection. And screening tests are very important. What is a screening? Screening involves the application of a test, an examination, or another procedure on asymptomatic subjects in order to identify a potential pathology at its earliest stage, when an intervention can significantly modify its natural history. Role of PSA in prostate cancer screening. PSA is a specific prostate hormone which is produced by prostate cells and which is secreted mostly in the seminal fluid. Its role is the liquefaction of sperm. PSA found in the blood is 30% free and 70% bound to various proteins. Different laboratories dose total PSA and free PSA. They can also dose the ratio of free PSA total PSA, which, if it is less than 10%, indicates the possibility of a prostate cancer. If PSA has never been measured, it is not recommended to start measuring with free PSA due to numerous errors. But we have to know that the PSA test can be confusing anytime because the PSA level can be lower or higher in some situations. So, low PSA is normal for all men to have some PSA in their blood. It can also be a high level, but it's important to know that higher levels are often sign of prostate cancers. But higher levels can also be for another reasons, such as a urinary or urinary tract infection, vigorous exercise, some medications, prostate stimulations like recent ejaculation or anal sex. So, if we know the other reasons of higher levels, we have no reason to be disturbed of these numbers. First of all, the PSA values should be compared over time, year after year, to detect its significant increase. And secondly, the same kits should always be used to measure PSA, which is why we recommend measuring PSA in the same laboratory. The patient should also not have had a urinary tract infection in the last 3 months, and care should be taken to record all medications he is taking, especially 5-alpha reductase inhibitors such as Avodart. The patient's age and prostate volume may also make it difficult to interpret PSA values. The American Urological Association suggests under 40, no screening. 40 to 54, no screening if you're at average risk. If you're at a high risk, you and your doctor can decide. 55 to 69, screening if the doctor suggests, and over 70 or less than a 10 to 50-year life expectancy, no screening. Here are included the studies of the review by the title, year, and authors of the studies. So the studies are founded and are chosen on the last 5 years that included our theme of study. On the first year, 2017, prevention of prostate cancer, morbidity and mortality, primary prevention and early detection. The second title, defining low-value PSA testing in a large retrospective cohort, finding common ground between discordant guidelines. The third study, PSA screening and molecular markers. The fourth study on 2020 year, prostate cancer screening among elderly men in Brazil, should we diagnose or not? And the last study, prostate cancer screening. So we are focused on conclusions of review studies. The first study, more than any other cancer, prostate cancer screening with a prostate-specific antigen test increases the risk of a man will have to face a diagnosis of prostate cancer. Active surveillance has the potential to uncouple overdiagnosis from overtreatment. Because of the close balance of potential benefits and harms, informed men should have the opportunity to decide whether PSA screening is right for them. The second study has this conclusion. Screening among younger men was frequent despite low rates of risk factors. High rates of comorbidity may limit life expectancy among older men receiving screening. These findings highlight the need for improved guidance with prostate cancer screening. The third study has the conclusion. Neither complete rejection of a PSA-based screening nor general PSA testing is a final solution to this dilemma. A risk-adapted PSA screening according to a baseline PSA, as well as serum markers, may reduce unnecessary diagnostic and therapeutic interventions and its attendant morbidities without a decrease in sensitivity. The fourth study says prostate cancer screening in men aged over 70 may be relevant in Brazil, considering the absence of systematic screening, higher prevalence, and higher probability of high-risk disease found in this age range of the population studied. The last one says, one of the major concerns regarding prostate cancer screening is overdiagnosis, which involves overtreatment of low-grade prostate cancers and decreasing the quality of life of the patient by adding treatment, associated side effects, and psychological harm when in reality cancer would not have caused any clinical problems in the patient. This outcome can be overcome by active surveillance or monitoring. So, in conclusion to this review, we can say that the literature controversy suggests that no standards of care exist for prostate cancer screening today. Until there is agreement in guidelines between major professional organizations who have weighed in on this topic, patients and physicians should be encouraged to consider engaging a shared and informed decision process concerning screening for prostate cancer. Further, the evidence for and against prostate cancer screening remains highly controversial. The availability of serum prostate-specific antigen (PSA) as a marker has encouraged its use to diagnose both cancer and cancer recurrence. Some clarity is required about its precise role in clinical practice. The studies recommended shared decision making for men aged 55 to 69 years, considering PSA-based screening, a target age group for whom benefits may outweigh harms. Outside this age range, PSA-based screening as a routine could not be recommended based on the available evidence. However, many men will experience potential harms of screening, including false positive results that require additional testing and possible prostate biopsy, overdiagnosis and overtreatment, and treatment complications such as incontinence and erectile dysfunction. In determining whether this service is appropriate in individual cases, patients and clinicians should consider the balance of benefits and harms on the basis of family history, race, ethnicity, comorbidity, medical conditions, patients' values about the benefits and harms of screening and treatment-specific outcomes, and other health needs. For your attention.